Welcome back to Clinically Clear, guys. Today we'll be checking out some other common nasal septal conditions. Not all of them are common, but some important nasal septal conditions. So let's get started. So first, let's look at septal fractures, and by septum I mean just the nasal septum. So due to trauma from any side I get hit on the nose, it can lead to septal fractures. Now, either it can be an anterior blow or it can be a lateral blow. So let's say there's an anterior blow. When there's an anterior blow, the type of fracture is known as Jarjaway fracture. In Jarjaway fracture, the fracture line from the nasal spine, it runs horizontally backwards to the perpendicular plate of ethmoid. So it runs horizontally backwards. Whereas when there is a lateral blow, it is known as Chevrolet fracture. So lateral blow leads to Chevrolet fracture, where the fracture line runs vertically upwards from the nasal spine. It runs vertically upwards onto the roof of the nasal cavity. So Chevrolet, lateral blow, vertical fracture, horizontal fracture backwards, anterior blow, Jarjaway fracture. So what are the symptoms? Symptoms of any fracture, just like any other fracture, you have pain, swelling, and redness. But let's say the pieces of the septal cartilage tear through the septal mucosa. Then what will happen? It can lead to epistaxis. But now we have the septum is broken into many pieces, but it does not tear through the septal mucosa. So what happens underneath the mucosa? There is collection of blood. Blood collects underneath. If it does not tear the mucosa, that will lead to septal hematoma. So pain, redness, swelling, epistaxis if it tears through the mucosa. If it does not, then septal hematoma. How do you treat it? You surgically realign all the pieces of the septal cartilage. And if there is any septal hematoma, you do incision and drainage. That is treatment. Complications, as I said, septal hematoma itself is a complication. Then fracture of the nasal septum, right? So there will be some external deformity of the nose and can lead to deviated nasal septum because of the trauma. Next, coming to something very important, septal perforation. Now, septal perforation is basically, what do you think? It is a hole in the nasal septum, right? So, based on the cause, you have various types. Traumatic cause, like ornaments. Some people keep, nose rings through the septum. Usually, it's through the lateral wall, but sometimes it's even through the septum. So, ornaments. Then, any septal fractures, during any septal surgery, any trauma, or any rhinolith stone like object that is present in the nose. So these all can cause continuous trauma on the nasal septum, leading to the perforation. Then you have some pathological conditions. One very important one is nasal myiasis, where you have maggots in the nasal septum. This condition, you will treat it with turpentine oil or chloroform wash. Whenever there is nasal myiasis, you will treat it with turpentine oil or chloroform wash. But apart from these nasal myiasis maggots, which eat their way through the septal cartilage, you can have septal abscess causing necrosis of the septal cartilage. You can have chronic granulomatous diseases. If the perforation in the bone, it can be due to syphilis. If it's in the cartilage, it can be due to tuberculosis and leprosy. If it is in both the septum and in both the cartilage and the bone, then it can be something known as Wegener's granulomatosis. So these are all some pathological causes. It can be idiopathic septal perforation, just the perforation. We don't know the exact cause. It can be chemical causes of septal perforation, like overuse of topical nasal decongestant, overuse of topical steroid nasal spray, cocaine snorting addiction. So all these chemicals, they cause excessive vasoconstriction, and when they cause vasoconstriction, it leads to ischemia. Ischemia causes necrosis of the septal cartilage, leading to perforation. So these are all the causes. Symptoms depends on the size of the perforation. If you have very small perforation in the nasal septum, there will be whistling sound as we breathe in, because the air flows in through that perforation. So whistling sound. Large perforations won't produce whistling sound, but what happens is, because the mucosa because of excessive drying effect, the mucosa starts to crusting, and when you remove those crusts of mucosa, dried out crusts of mucosa, it can lead to epistaxis. And treatment also depends on the size. If you have small perforation, you can just extend the mucosal flaps. Let's say there's a small perforation and the mucosa is present like that. You can just extend this mucosal flap and then make it join. So you can extend the mucosal flaps and make it join. That is if it is a small perforation, or you can even introduce a small plastic flap. But for large perforations, you can't do that. You have to give something known as septal buttons. These are silastic septal buttons. So these silastic septal buttons, they go and plug the hole, and you give ointments to prevent the crusting. So this is about septal perforation, the traumatic cause, pathological cause, idiopathic and chemical, symptoms and treatment depending on the size of the perforation. Next, coming to septal hematoma. Basically, when blood collects underneath the mucoperiosteum and the mucoperichondrium of the nasal septum, as you can see, blood collection, then it is known as septal hematoma. It can be immediately after any trauma, following any septal fracture, trauma leading to septal fracture. Immediately you will have a swelling there, or it can be because of any septal surgical procedures as a complication, or it can be a spontaneous septal hematoma without any trauma in bleeding disorders, hemophilia, stuff like that. Symptoms: because of the collection of blood there, you'll have a lot of pain and redness and tenderness and pressure over the nasal bridge. And of course, because of collection of blood, there's a swelling in the nose, right? So there'll be bilateral nasal obstruction, very, very important. Bilateral nasal obstruction that will cause its own complications like anosmia, recurrent, again sinusitis, again recurrent rhinosinusitis, rhinolalia clausa, etc. And when you do anterior rhinoscopy, you can see soft bilateral. This is sign actually. This is sign. When you do anterior rhinoscopy, you can see a soft bilateral smooth round swelling in the nasal septum. Treatment: if it is a very, very small hematoma, then you can just aspirate it using a needle. But large hematomas, septal hematomas, you have to do incision and drainage within 72 hours. Very, very important. Immediately you detect, patient comes to you with history of trauma, there's a large swelling in the nasal septum and patient is feeling pain, you have to immediately think of septal hematoma and incise it and drain it. Where will you make the incision? The incision is parallel. It is a horizontal incision parallel to the nasal floor. And then once you drain it, you'll pack the incision with cotton gauze or whatever, so that blood does not reaccumulate. We don't want recurrence. And to prevent the infection, you will give systemic antibiotics. Infection will lead to septal abscess. We don't want that to happen. But let's say you don't do incision and drainage, you let it stay even beyond 72 hours. Then what will happen? Two things can happen. Either there can be a secondary bacterial infection leading to septal abscess, or there can be fibrous organization of the hemorrhage leading to permanent thickening of the septum. As I told, in one of the types of deviated nasal septum, bilaterally thickened nasal septum, one of the main causes is fibrous organization of septal hematoma when you leave it untreated. So causes, so what is it? Collection of blood underneath the mucoperiosteum, mucoperichondrium, caused by septal fractures, spontaneous and bleeding disorders, or surgical complication, pain, redness, etc., bilateral nasal obstruction, and sign is a soft bilateral smooth round swelling. Incise horizontal incision parallel to the nasal floor, drain it within 72 hours, pack it with cotton to prevent reaccumulation, give antibiotics to prevent septal abscess. If you don't do all that, either it will go into a septal abscess because of infection, or fibrous organization of the hemorrhage will lead to permanent thickening of the septum. Next, coming to septal abscess. As I said, what will happen? Either it can be a secondary infection of a septal hematoma, or sometimes just a local infection like vestibulitis or furunculosis vestibulitis. These all can lead to septal abscess because of the infection. Again, the symptoms are very, very similar. You have pain, tenderness, pressure over the nasal bridge. You have bilateral nasal obstruction because again, you have a swelling in the septum, right? But apart from that, because it is an infection, you have fever and chills, and also you have tender submandibular lymphadenopathy. Everything else symptoms is same as septal hematoma. You have bilateral nasal obstruction, you have pain, pressure and tenderness over the nasal bridge. And when you do anterior rhinoscopy, you can see a soft swelling, bilateral swelling. But here the difference is, because it is an infection, you have fever and chills and you have tender submandibular lymphadenopathy. Treatment is also the same. Again, incise and drain. But here you will not drain the blood. It is an abscess. You will drain the pus. You will take out the necrotic pieces of cartilage and immediately start them on empirical antibiotic therapy. Send the pus sample for culture sensitivity testing. Once it comes back, switch over to specific antibiotics. That is one more thing. Then the incision in septal hematoma was a horizontal incision parallel to the nasal floor. Here at the most dependent part of the abscess. Basically, wherever you have the most pus collected, there you'll make the incision so that easily you can drain out the pus. And for 3 days, you have to keep reopening the incision, draining any pus. Reopen the incision, drain any pus, close the incision. For 3 days, you have to keep doing that. Let's say you don't do any of that. You let the infection run loose. Then what will happen? Main problem is necrosis of septal cartilage. Basically, septal cartilage, as I told, it supports the column, it supports the tip, it forms a partition. So now that the cartilage goes into necrosis, the supra tip, this is the tip, supra tip gets depressed. Understood. The columella, the dorsal column, not the columella, the dorsal column, which is normally here, it gets depressed. So dorsal column depression, supratip depression, both these lead to a deformity known as saddle nose. This appears like the saddle of a horse, saddle nose. Then, as I told previously, necrosis of the septal cartilage is one of the pathological causes of septal perforation. That is also one more thing. And all this comes into the dangerous area of the face. So the infection can spread. Meningitis, cavernous sinus thrombosis, etc. Done. So, as a result of secondary infection of septal hematoma or local infections like furunculosis and vestibulitis, same symptoms as septal hematoma. To that, you will add fever, chills, and tender submandibular lymphadenopathy. You will incise, you will drain, you will remove the pus, you will remove the necrotic pieces of cartilage, antibiotics, and reopen the incision to drain any excess pus. If you don't do all that, complications is main is necrosis of septal cartilage. It will lead to saddle nose deformity and septal perforation, and infection can spread in the form of meningitis and cavernous sinus thrombosis. Now, one thing very, very important, if someone comes with unilateral foul smelling nasal discharge, it is due to nasal obstruction, foreign body. Foreign body nasal obstruction leads to unilateral foul smelling nasal discharge. And when is it an emergency? Let's say of some batteries, stuff like batteries and all is emergency. You have to treat it right away. But otherwise, it is not an emergency for unilateral nasal obstruction due to foreign body. Next is nasal synechiae. See, nasal synechiae is simple. Sure, this is the nasal septum. This is the lateral wall of the nasal cavity. You can see mucosal bridging. So, mucosal bridges between the septum and the lateral wall. Basically, what happens during FES, during surgery, any foreign body, during nasal packing, if I cause any injury to the walls, then it exposes the raw surfaces. And when the raw surfaces are exposed, when during healing, both sides you have raw surfaces, so during healing they bridge, so that will lead to nasal synechiae, and this obviously it causes obstruction, so you have nasal obstruction. And then the treatment is you will surgically resect the nasal synechiae, and once you resect it, you want to prevent them from getting joined back together, so you'll place gel foam pads on both the sides, and once you place gel foam pads on both sides, they heal on their own. There is no mucosal bridging. So that is it for nasal synechiae. 3 marks max. That's it. Thank you for watching.